Am I audible also?
Yes, sir. Perfectly.
Okay. Can the students listen to me and hear me, see me?
Yes, sir. Sir.
Can you see me?
Yes, sir.
Yes, sir. On my screen?
Screen is visible, sir.
Okay. So we'll start with we'll have some spot test today. We'll show you about 40 to 50 spot tests. So start with the first one. Volunteers to answer. Describe the X-ray and come to your diagnosis. Anybody who would like to volunteer a diagnosis? Describe and come to a diagnosis. What are the most prominent structures that you see in the X-ray chest? What is this? So this is an X-ray chest. Look at there's some mild cardiomegaly. What is this structure? Anybody? In the lateral border, in the left lateral border, uppermost structure is
Aortic
Aortic knuckles.
aortic knuckle. Is it abnormal, normal, dilated? What do you think?
Dilated.
Maybe borderline, but maybe slightly dilated. Maybe right. Okay. What is this?
Empty.
calcified.
What is this? This prominent structure? Pulmonary artery segment. So it's a pulmonary artery segment. When you see that there is a dilated pulmonary artery segment, what are the possibilities that you should think about?
Idiopathic pulmonary artery hypertension.
Idiopathic dilated pulmonary dilatation 1, 2.
Poststenotic dilatation.
Poststenotic dilatation, very good.
Idiopathic pulmonary artery dilatation, sir.
That is already mentioned.
Top with pulmonary atresia.
Top with?
Pulmonary valve, absent pulmonary valve, sir.
Okay, right. In the presence in patients with pathology of Fallot, sometimes absent pulmonary valve can give rise to a prominent or dilated pulmonary artery segment. Okay, right, yes.
Ductus, 18 ductus.
So important reasons you have not mentioned.
Left to right, sir.
Yes, increased flow. If there is an increased flow, as in AST, BST or PDA, pulmonary artery segment can be prominent. Yes, what is other reason? What is the other reason for dilated pulmonary artery segment?
Aortopulmonary collapse.
Pulmonary collapse need not give rise to, because very often they may have pulmonary atresia, and that is the most important reason for patients to pulmonary collaterals. In that case, the pulmonary artery segment need not be prominent. Pulmonary artery hypertension. Patients with pulmonary artery hypertension can have prominent pulmonary artery segment. Now, we are finding a prominent pulmonary artery segment in this patient. So, what are the other additional findings that you look for in order to come to a diagnosis?
Endon appearance.
Endon vessels. Are you seeing endon vessels?
Yes, sir.
Yes, I think you can see plenty of endon vessels. One is here, and some are here, and you can see through this cardiac shadow, you can see end vessels. So multiple end vessels are seen. What does that mean?
It's pulmonary hypertension.
It's not pulmonary hypertension. Increase in the pulmonary blood flow. The end vessels are indicative of increased pulmonary blood flow. Pulmonary plethora is increased blood flowing through the pulmonary system. So then only you will get multiple end vessels. So you have to think of the possibility like ASD, BSD, PDA, P window. So out of these, which one do you think is most likely in this patient? This is the X-ray of a patient who is 55 years old.
AST is bad.
ASD, I think. Now, is there evidence of pulmonary artery hypertension? Is there evidence of pulmonary artery hypertension? How do you look for evidence of pulmonary artery hypertension?
The centron vessels and my MPA dilators.
The pulmonary artery hypertension, there is no need of internal vessels. Internal vessels are usually, we look for internal vessels to diagnose increase in the pulmonary blood flow. So, what are the things that you look for to diagnose pulmonary artery hypertension?
RARV dilatations.
No, RARV dilatation, yes, it is a secondary effect, but before that you have to diagnose pulmonary artery hypertension. RARV can be dilated due to other reasons like tricuspid regurgitation.
Cephalization.
Cephalization is in what condition do you get cephalization?
Pulmonary venous hypertension. Pulmonary venous hypertension.
Yes, in pulmonary venous hypertension, when there is pulmonary congestion, you will get cephalization. In pulmonary artery hypertension, what do you get?
Pulmonary artery dilatation.
Let me finish. Have I taken a class on how to interpret X-ray chest, X-ray chest? No, students, have I taken a class for you on how to interpret X-ray chest for the cardiac to diagnose cardiac conditions?
Pruning, sir. Peripheral pruning.
No, that's not my question. Now I want to ask a question. If you are not clear about interpreting the X-ray, I think I can take a class on how to interpret the X-rays properly.
Sir, next class.
Yes, sir.
X-ray.
Okay. So now go ahead with spotters. Yes. So here we see cephalization is for pulmonary congestion. So,
Peripheral pruning.
peripheral pruning is for
Pulmonary arterial hypertension.
pulmonary hypertension. It is known as centralization, where the main pulmonary artery in the region of the pulmonary hilum will be very prominent, and as you track it to the periphery, there is a certain cutoff, and periphery does not have any vessels. That is known as peripheral pruning, which is highly suggestive of pulmonary artery hypertension. Is there a peripheral pruning in this patient? I think there is some degree of peripheral pruning. You can see that large central vessels are seen. Here also you can see large central vessels. But as you go to the periphery, it is significantly cut off, indicating that there is some degree of pulmonary artery hypertension. So this patient has got evidence of increased plethora, indicating left to right shunt, and also evidence of pulmonary artery hypertension as evidenced by peripheral cutoff. So what is the condition that you are dealing with? This patient is about 60-65 years old. And whenever you see such large, prominent pulmonary artery segment and plenty of internal vessels, you must always think of the possibility of atrial septal defect. So this is a X-ray of a patient with atrial septal defect, with still having thoracic flow. At the same time, patient has started developing pulmonary artery hypertension. Okay, we'll go to the next one.
X-ray chest PA view showing ductal calcification.
Yes, there's a ductal, very good. There's a ductal calcification.
As well as enlarged main pulmonary artery.
Yes, aorta is prominent, main pulmonary artery is prominent, yes. And if you look at here, the right pulmonary artery is hugely dilated. What about the left pulmonary artery? What about the left pulmonary artery?
Yes, sir.
Hmm? Compared to the right pulmonary artery, which is hugely dilated, you are not seeing much of a left pulmonary artery. What can be the reason that the main pulmonary artery is grossly dilated? You can see the peripheral pruning. The vessels are not seen in the periphery, indicating that there is evidence to suggest severe pulmonary artery hypertension. But the left pulmonary arteries are not very prominent. What may be the reason? What may be the reason that one pulmonary artery is very grossly dilated?
Left pulmonary artery.
Yes, yes.
Left pulmonary artery stenosis.
Yes, there is a left pulmonary artery stenosis. The peripheral pulmonary artery stenosis resulting in less of blood flowing to the pulmonary artery, and it is not grossly dilated. What is the condition in which you can get PD with peripheral pulmonary artery stenosis?
Congenital rubella syndrome.
Congenital rubella syndrome. So this is a patient who had a congenital rubella syndrome, has developed severe pulmonary artery hypertension, Eisenmenger syndrome, and has got evidence of peripheral pulmonary artery stenosis. So and you can see the calcified ductus is calcified. You can see very large, prominent central pulmonary artery indicating with peripheral cutoff indicating severe pulmonary arterial hypertension. So the previous one was actually, and usually when there is a shunt lesion, the pulmonary artery segment is prominent. When there is a shunt lesion and the aorta is very prominent, you must always think of the possibility of patent access arteriosus. It's much simpler. You should be able to diagnose.
Van appearance, pericardial effusion.
Yes, pericardial effusion is a possibility. Any differential diagnosis?
Carbovinum, syphilitic AR. Carbovinum, syphilitic AR.
AR usually very significant LV enlargement, indicating that it will dip down. But here, if you look at carefully,
Sir, narrow pedicle with cardiomegaly.
there is a minor prominence of the left border of the heart. What may be the reason for this slight prominence?
Rheumatic multivalvular disease.
Not rheumatic multivalvular. When you see this type of a large shadow,
Epstein's possible.
if it's a multivalvular heart disease, what is the valve usually affected in rheumatic heart disease?
Mitral valve. Mitral stenosis.
Mitral valve. When there is a mitral stenosis or mitral regurgitation, and if there is evidence of LV dysfunction, what do you find in the XHS PAVO, in the lung vasculature?
Can be Epstein anomaly.
That's right. This is actually X-ray of an Epstein's anomaly. Why did you say it's Epstein's anomaly?
It's a narrow pedicle.
Narrow.
Pedicle. Yes, there's a presence of a narrow pedicle with a huge cardiac shadow.
Massive cardiac
And if you are very careful, slight prominence of the left border here. That is the one which differentiates the Epstein's anomaly from pericardial effusion. The diagnosis of pericardial effusion also should be entertained. But if you are recognizing a slight prominence of the left border here, then you should think of the Epstein's anomaly as the first possibility and pericardial effusion as the second possibility. Why this prominence? What is the prominence due to? What is this prominence due to?
Left atrium.
No, in this in Epstein's anomaly, left atrium is not dilated. What is the reason for slightly dilated? RVOT, yes, it is very good. It's RVOT. When you look at on the left border of the heart. Structures which can create an impression on the left border of the heart. First is aorta, pulmonary segment. Then there is a left atrial appendage. Then at the same region can be the RV outflow. So that is how it happens. The pulmonary segment, the aorta, pulmonary segment, left atrial appendage, as well as the right RV outflow. So then the rest of the left border of the heart is mostly formed by the left ventricle. So the RV outflow can be seen just below the pulmonary artery segment. So here what you see is the RV outflow, and RV outflow is dilated in an Epstein's anomaly. Why the RV outflow is dilated? That is because there is no inflow, or the RV inflow has been taken over by the airtrays to go to the RV, and so there is very little RV inflow. The cavity of the RV is very much reduced. So whenever the blood comes to the RV, it can be accommodated only in the RV outflow, resulting in RV outflow dilatation. So patients with Epstein's anomaly will have dilated RV outflow, and they will have the vessels in the lung field will be very, very, very thin and scanty, and narrow pedicle and a very hugely dilated right atrium, very prominent right atrial enlargement. So very highly suggestive of Epstein's anomaly. So this is a case of Epstein's anomaly. What do you find there?
Dilated RA is dilated.
RA is dilated. You should not start with RA. Start with the general comments about the centralization. Everything is fine. Is there a cardiac enlargement?
Yes, sir.
Yes, sir.
There is a significant cardiac enlargement. Cardiac enlargement means what?
CT, chamber enlargement.
Cardiac enlargement is due to what?
Chamber dilatation or vascular.
RV type.
No, so I'm not asking you anything RV type. When there is a cardiac enlargement, what are the things which should cross your mind? One cause for cardiac enlargement is volume overload conditions. Whenever there is a volume overload, that will progressively result in enlargement of the heart. The respective chambers can be enlarged. The volume overload means either shunt lesion or a regurgitant lesion. The next cause for cardiac enlargement is myocardial disease. When there is a dilated cardiomyopathy, that can result in enlargement of the heart, and cardiac enlargement can happen. And then patients with stenotic lesions, especially aortic stenosis, if they progressively go in for heart failure, then the heart can be dilated. So there are mainly three situations where the heart can be dilated. One, in patients with primary myocardial disease, in patients with volume overload. Two, patients with primary myocardial disease, which could be ischemia to the myocardium, coronary artery disease, myocardium post-MI, or it can be dilated cardiomyopathy. And third reason is patients with stenosis, especially aortic stenosis patients who develop LV dysfunction and have cardiac enlargement. So this patient has got significant cardiac enlargement, and you should look for any evidence to take a correct diagnosis. You or somebody has pointed out that there is a right atrial enlargement. What is the condition where there can be right atrial enlargement associated with volume overload?
ASD.
ASD. ASD is the condition where there can be cardiomegaly secondary to volume overload, and the right atrium can be significantly enlarged. So you should look for evidence to diagnose AST. So AST is a left to right shunt lesion, so you should look for end-on vessels. Can you see end-on vessels? Here you should be very careful. So you can see end-on vessel here.
Yes.
You can see end-on vessel here. There is a vessel here. So there is a sufficient number of end-on vessels for you to diagnose that there is an evidence of a left to right shunt. And since the right atrium is enlarged and the pulmonary segment also is very prominent, you can think of the possibility of atrial septal defect. So this is a case of atrial septal defect. With is there evidence of pulmonary artery hypertension in this patient?
Yes, sir.
What is evidence?
Main pulmonary artery is dilated.
Yeah, the main pulmonary is dilated. That is over here. That indicates even shunt lesions. You can see main pulmonary artery is significantly dilated.
Right pulmonary artery is also dilated.
Yes, right pulmonary artery is grossly dilated. The left pulmonary artery cannot be clearly seen.
Peripheral pruning.
Endon vessels.
Peripheral pruning is not there actually. Actually, you can see that vessels can be traced to periphery. You can see the vessels here. You can see the vessels here. So you can see the vessel here. You can see good number of vessels which are reaching the periphery. That also is a sign of normally only one or two vessels reach periphery. If more than two vessels are reaching periphery, that also can be taken as a sign of increased pulmonary blood flow. So this patient has got increased pulmonary blood flow with very little evidence of pulmonary arterial hypertension. So it is a case of atrial septal defect, left to right shunt, probably no significant pulmonary arterial hypertension. So moving. Okay. Diagnosis.
Tetralogy of Fallot.
Oh, very good. Tetralogy of Fallot. Why did you diagnose tetralogy of Fallot?
So it's a boot-shaped heart, sir, with oligamic lung fields.
It's a boat-shaped heart because
Oligamic.
boat-shaped heart is actually the shifted apex, and the cardiac shadow makes an acute angle with the diaphragmatic shadow. The angle between the cardiac shadow and the diaphragmatic shadow is an acute angle, and also the apex of the heart is lifted up. So it is highly suggestive of RV type of apex. And since here the pulmonary segment is not practically is very flat and not very prominently seen, a possibility of tetralogy of Fallot can be considered. Very often these patients can have a large aorta also, and also you should carefully look for whether the patient is having right side aortic arch. What is the percentage of patients have right side aortic arch in tetralogy of Fallot?
25 to 30%.
Yes, around 25%. 25% of patients can have right side aortic arch. So here you can see that you are not sure about the right side aortic arch. I don't think it's right side aortic arch, but you can see a significant or large aorta which has become very prominent and very flat and insignificant pulmonary artery segment. Obtaining of the apex suggests you a RV type of apex with an acute angle between the cardiac shadow and the diaphragmatic shadow, or suggests you of tetralogy of Fallot. And if you look at the vasculature, there's very little vasculature seen in the lung field, indicating oligemia. This is a 3-day-old baby. What did you say? What did you say? You try, you may be right.
Digeorgia.
Digeorgia syndrome.
Digeorgia. Yes, sir.
Not exactly. They are usually associated relations. Here what you see is that one or 2 points. One, the pedicle is very narrow. In a newborn baby, what will happen to pedicle or in the region of the pedicle? What is the structure which is in the region of the pedicle in a newborn baby?
Thymus.
Thymus.
Thymus, yes, thymus is there. And thymus, at what age does the thymus disappear?
Puberty.
Hmm? Puberty, oh, that's too much. When does the thymus disappear? Usually after the age of 2. So usually it will be present up to the age of 2. Here 3-day-old baby, the thymus has disappeared. Usually thymus disappears when there is a stress situation. If the baby is having stress situation even in the uterus, that can result in disappearance of the thymic tissue. And the most classical condition where the thymus can disappear immediately after delivery is transposition of great arteries. So if you don't find any thymic tissue, you should always think of the possibility of transposition of great arteries. And also, some people have described that there can be an egg on side appearance of the extra chest in patients with transposition of great arteries. If you are very careful here, you can consider that this is the smaller end of the egg and this is the larger end of the egg. So the egg is placed on side. And you can see that there is some plethora indicating increased pulmonary vascularity. So all put together, absent thymus, the egg on side appearance, increased vascularity, all these put together, you can make a diagnosis of transposition of great arteries. What do you find here?
Calcified LV aneurysm.
Very good, excellent. There is a calcification seen here. Seems to be whenever there is a calcification, what are the structures which can be calcified in the heart?
Pericardium.
Pericardium,
LV.
LV aneurysm, infarctus segment, where it can be calcified, yes.
Ductus.
Ductus can be calcified, very good.
Aorta. Aortic knuckle.
Aorta can be calcified.
Mitral annulus.
Yes, valves can be calcified. Anything else which can be calcified?
Myxomas.
Hmm?
Myxomas.
What are scattered areas of calcification? Yes. Myocardium can be calcified. Myocardium can be calcified in certain disease states like endomyocardial fibrosis, or it can get calcified following myocardial infarction. So myocardium also can get calcified. So whenever you see calcification, you should always ask for a lateral view. Lateral view will help you to differentiate between pericardial calcification and other types of calcification. Here, as somebody has slightly pointed out, this is an LV aneurysmal calcification. LV aneurysm calcified. Yes.
Here, pulmonary venous congestions.
Why do you want to say pulmonary venous congestion? It is frank pulmonary edema.
Yes, sir.
There is bilateral fluffy shadows are seen. The patient is having acute pulmonary edema. But the patient does not have any cardiac enlargement. So what are the conditions that you should suspect as the cause for acute pulmonary edema in this patient?
Prostatic valve. Prostatic valve, stuck prostatic valves.
Yes, and this patient is having a prostatic valve. So first you should say that. If you are very careful, you can see that the patient is having a prostatic valve here. And stuck prostatic valve can happen in thrombosis of the prostatic valve that can result in acute pulmonary edema. So, what are the conditions you should suspect in a patient with a normal sized heart developing acute pulmonary edema?
Renal artery stenosis. Renal artery stenosis.
No, don't go to acute hypertension. Where an acute rise in blood pressure sometimes can result in acute pulmonary edema. Very good. 2.
Obstructed TAPVC can.
Which one?
Obstructed TAPVC.
Obstructed TAPVC. Obstructed TAPVC, they usually will have cardiac enlargement because the volume of blood will come to the heart and flowing through the different chambers of the heart will give rise to dilatation. So patients with TAPVC will have dilated heart. So that cannot be considered as normal heart with acute pulmonary edema.
Acute severe MR.
Severe MR, acute, okay, acute MR. Acute MR, acute AR. What else? Mitral stenosis. Mitral stenosis is very severe. Mitral stenosis patients sometimes can have a normal sized heart and they can develop acute pulmonary edema and congestion. So patients with acute normal sized heart with acute pulmonary edema, you should always think of the possibility of mitral stenosis. Here is an example where a calcified and stuck prosthetic valve resulted in acute pulmonary edema. So it's the thrombosed valve, not calcified, thrombosed valve. Thrombosed valve resulted in acute pulmonary edema. So this is a case of prosthetic valve thrombosis resulting in acute pulmonary edema. ECG.
A trifascicular block.
Very good. Why did you say trifascicular block?
There is a left anterior hemi block
Very good.
with RVV and prolonged PRs.
The right bundle branch block and prolonged PR interval. So all put together fits in with the diagnosis of trifascicular block. What else is there?
Your PVT antral MI, sir.
Yeah, the patient is having a previous anterior MI or evolving anterior MI resulting in right bundle branch block, left anterior block, and prolonged PR interval satisfying the criteria for the diagnosis of trifascicular block. Yes, very good. Okay. Notification.
Hyperkalemia.
Hyperkalemia. Why did you diagnose hyperkalemia?
That's a tall dented T wave, sir, in mid-precordially.
Yes.
And there's a atrial paralysis.
Atrial paralysis. Okay, there is no atrial PVs are seen. So it suggests you hyperkalemia. Very good. Can you tell me the serial electrocardiographic changes of hyperkalemia?
It's a tall dented T waves.
Yes.
Atrial paralysis.
Very good.
QRS widening.
Very good.
And sine wave patterns.
Very good. Diagnosis. What is arrhythmia? You describe it and tell me the arrhythmia. This is a rhythm strip. So what is the diagnosis? You describe the rhythm strip. Any one of you?
High grade AV block.
High grade AV block. Yes, that is there. What is the type of AV block this patient is having?
So 2:1.
This is not 2:1. Here there is a normal sinus rhythm, normal conduction with broad QRS complex. And what is happening here?
Blocked PV.
None of these PUs are conducted. Here is a PU, here is a PU, here is a PU. So all PUs. PUs. Till that here, this is the only PU which is conducted. All the PUs are not conducted. And then what happens? That is followed by, what is the arrhythmia following the block? Patient is having
2:1 AV block.
2:1 AV block, very good. Patient is having 2:1 AV block, there is a P wave, there is another P wave, there is a P wave, there is another P wave, 2:1 AV block. That is followed by, ultimately down for normal sinus rhythm. So this is a case of normal sinus rhythm. The patient is having a broad QRS complex, indicating that maybe having a bundle branch or a partial bundle branch.